Spin your passion into a business with Shopify and break sales records with the world's best converting checkout. Let's hear that one more time. The world's best converting checkout. Shopify's legendary checkout makes it easier for customers to shop on your website, across social media, and everywhere in between. Now that's music to your ears. Any way you spin it, you can be a smash hit with Shopify. Start your $1 a month trial today at shopify.com/records.
Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Pleased to welcome you to today's ADHD Experts presentation titled Substance Use Disorder and ADHD, Safe, Effective Treatment Options. Leading today's presentation is Dr. Timothy Wilens. Dr. Wilens is an associate professor of psychiatry at Harvard Medical School in Boston and a psychiatrist at Massachusetts General Hospital. His research interests include the relationship between ADHD, bipolar disorder, and substance use disorders, and the treatment of these disorders across a person's lifespan. Dr. Wilens' peer-reviewed articles have been published in the Journal of the American Medical Association, the American Journal of Psychiatry, and in the journal Pediatrics. In today's webinar, Dr. Wilens will explain the relationship between substance use disorder and ADHD. Adults with untreated ADHD are at higher risk for substance abuse than their neurotypical peers. Dr. Wilens will discuss treatment strategies for substance abuse and also approaches to prevent substance misuse. We'd like to begin today's webinar by asking two poll questions to our live audience. The first question is, in your personal and or professional experience, has marijuana use among patients with ADHD increased in recent years with widespread legalization in many states? Our second poll question is, have you or someone you know been denied your ADHD medication because of substance abuse concerns? Please select your answers and comment in the text box under the video player to tell us more. You will see the poll results when you submit your response. And while you do that, I'll point out that live participants may submit questions anytime during the live event. To download the slides, click on the Event Resources section of your webinar screen. If you're interested in the Certificate of Attendance option, look for instructions in the email you'll receive about an hour after the live broadcast. A transcript of today's event will be made available in the coming week. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 440 to access the slides, the webinar replay, the Certificate of Attendance option, and the webinar transcript. And if you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine. In the forthcoming spring issue, you'll learn about the latest studies on stimulant use and heart health. And here's a hint, it's good news. And you won't want to miss our cover story on how to fix relationship problems when ADHD is in the mix. Our expert therapists weighed in with the practical solutions they recommend to their clients. Subscribe to Attitude Magazine today for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Finally, the sponsor of this webinar is Inflow. Inflow is the #1 app to help you manage your ADHD. Developed by leading clinicians, Inflow is a science-based self-help program based on the principles of cognitive behavioral therapy. Join Inflow today to better understand and manage your ADHD. Click the link on screen to learn more. Attitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without further ado, I'm so pleased to welcome Dr. Timothy Wilens. Thank you so much for joining us today and for leading this discussion.
Thank you so much, Carol. I really appreciate it. And thank you, Attitude, for asking me to be part of this. This is an area that I absolutely love. Many people have heard me speak on this, and it's an area that I've been researching for a number of years. I'm a researcher, but I also treat a lot of individuals. I do a lot of psychopharmacology, do a lot of ADHD psychopharmacology, and I'm also working substance use and help oversee 3 different detox units and oversee our addiction services at the hospital. So the natural jam is when ADHD, substance use disorders, and stimulant use, misuse sort of co-occur. Here are my disclosures. I do work with the Food and Drug Administration and the National Institute of Health, and I appreciate their funding to my laboratory. In addition, I work with a company working in new therapeutics for substance use disorders. The rest is really more clinical care, working with different facilities, including Massachusetts General Hospital. So the objectives for today are to really understand the relationship between substance use disorders and ADHD and identify treatment strategies for substance use and ADHD. And then certainly a lot of people are concerned about, stimulants are controlled substance. What do we know about stimulant misuse? So we're going to do all of this in about 30 minutes or so we have plenty of time for questions. So to remind people, this is sort of the world according to ADHD. The prevalence of ADHD, and most of you can recite this back to me, is about 6 to 9% of kids, about 4 to 5% of adults. This is a picture in blue of where there's been prevalence studies where we know ADHD is. And you can see most of the world is blanketed on terms of knowing the rates of ADHD. We know that it has a persistent course into adolescence. 3/4 of kids will continue to have it into adolescence. And about half will have ADHD into adulthood. Some get better. Some have only a few symptoms, don't need treatment, but at least half are going to have the full, have issues with ADHD that are going to require treatment in adulthood. It has a lot of psychiatric co-occurring problems. We're going to focus on one of them today. I don't need to tell you that impairment is a substantial issue, particularly if you develop substance use disorder. And to remind you, the diagnosis is by DSM criteria. It's a clinical diagnosis, which means somebody sits down across from you and makes the diagnosis. You don't need neuropsych testing. You don't need diagnostic systems, but they can be evidentiary. That is, they can help you in terms of making the diagnosis. And I want to underscore this last one. I've done a lot of work in this area, so have many of my colleagues, and that is it responds well to treatment. This is a disorder that you can expect a good prognosis because you can treat it. I want to orient you to substance use, which you may not know so well. So if you look overall, this is the percentage of kids. These are teenagers by the time they're 18 who have substance use disorders. And if you go to the right, any substance use disorder, about 10% of our kids will have a substance use disorder. That isn't that they're just smoking a joint or something, but they have a full disorder. You're saying, well, that seems high, but in fact, pun intended, it's actually, we know that about 50% of substance use disorders start in childhood. So if you look at adults, half of theirs started before the age of 18, and that's kind of what's reflected here. When we look at the overlap of ADHD and substance use, let's start with this. This is the world of ADHD. You all know it well. And this is the overlap of substance use disorders. Substance use disorders is a bigger world than ADHD. But there is a substantial overlap. And you can see that a sizable proportion of ADHD in the untreated state develops substance use. And if you're starting with substance use disorders, that you can see that a number of individuals also have ADHD. And I'm going to walk you through that. So this is starting with substance use disorders. SUD is substance use disorders. That means you have a drug or alcohol problem, consequences, can't stop. You make criteria for an actual disorder. And we know that if you start with people who have a substance use disorder and you ask, do they have higher rates of ADHD? They do. And this looks at different drugs. This is old, but this is the first time we looked at it. Polydrug, opioids, cocaine, alcohol. You can see the high rates of ADHD, and more recently, if you look at all of the studies, and at the time there were about 29 studies, about a quarter of adults who start with an addiction. So you're looking at an addiction treatment center in adults, about a quarter have ADHD. Now, what's interesting is if you ask the question, if you're looking at teenagers who are getting treated for substance use, the rate is in the 50 to 60% range. Many of them have ADHD. So it really is a very common overlap. This is more complicated in terms of starting with, if you start with ADHD, what is the likelihood to develop future cigarette smoking here or substance use disorders? And all I'm going to tell you is if you're to the right of this one, that means there's no difference. That means your increased risk, in this case, is cigarette smoking, and here substance use disorders. And overall, the data in these studies, these are follow-up studies. You followed kids for years into young adulthood or adulthood. What they find is there's almost a 5-fold increased risk for cigarette smoking. And people ask about vapes. Yep, vapes now. Kids are just moving from cigarette smoking and they're doing vapes. So vapes, nicotine use, whatever, if you have ADHD. And how about substance use disorder? It's about a 2 to 3-fold increase. So you're 2 to 3 times more likely if you have ADHD that you're going to develop a substance use disorder. So something that we're concerned about. I mentioned in context to cigarette use, vaping. And what do we know about nicotine vaping and ADHD? Vaping is a significant issue. It's being asked now in all surveys. You're hearing about it all the time. So we know that there's high rates of nicotine use and vaping in ADHD versus or compared to those who don't have ADHD, the same age kids. There's just more nicotine use. Then if you reverse it, there's higher rates of ADHD in e-cig use compared to non. So if people are using nicotine and they're using these vapes, these things that look like flash drives or whatever, what you find is higher rates of ADHD in those kids compared to if you look at other mechanisms. So they really like vapes. Part of it is vapes give you direct nicotine, high concentrations, and you can put it into a medium that's flavored, so it tastes good. I feel like a salesman for vapes. That's not what I want to be doing, but I just want to say, why do kids use them? Nicotine may be experienced differently. So this is interesting work from colleague Scott Collins. And what he found is that if you give nicotine to individuals with ADHD compared to those who don't have ADHD, they get more pleasurable experiences. So they like it more. And the dislike, so you may not know about addiction, is most compounds that are misused out there in the world, opioids and other things, there's a like. Yeah, I like it this much. But there's also a dislike because it kind of makes you nausea, makes you not feel good. So it's a dislike. So with ADHD, with nicotine, the like goes up, but the dislike doesn't change. So the reward center of the brain says, yeah, I like this. I like it. And that may be experience why it's different. The other is that I've been very involved in this, that previous work has shown nicotine enhanced cognition functioning in ADHD. So, there's a lot of evidence out there that if you use nicotine-like medicines, they help ADHD. And in fact, nicotine does. If you put a nicotine patch on somebody, they actually will have better focusing, better executive functioning, sort of the secretary of the brain. So it must be this multiple things. Their reward centers are turned on to nicotine, and it may help them actually concentrate and focus better. Some things we know about substance use disorders, drug and alcohol issues associated with ADHD, is that you have more severe substance use. It's worse than those people who have substance use, don't have ADHD. We know there's higher rates of other issues. So it's not just, you have ADHD and let's say alcohol use disorder, but you also have anxiety, or you have conduct problems, or you have mood disorders. So there's usually something else, which makes it even more complicated. You're less likely to remit from the substance use. It's harder to get better, especially on your own. There's a longer course of substance use, almost twice as long for people who have ADHD. And there's lower retention in cigarette and substance use treatments. Pretty much every study has showed if you have ADHD, you drop out of treatment. Why is that important? Because retention in substance use treatment is really highly linked to success. You do better if you stay in treatment, a lot better. I'm just going to give you a quick tutorial on what are some of the things that we think are involved with ADHD and addiction in terms of neurosystems. And what we think is involved is this is the eyes. If you're looking, this is sort of a cut like this. So it would be me looking this way. The eyes would be here, and this is the back of the brain. This part of the brain right here is where ADHD sort of lives. It's the prefrontal frontal area of the brain, and this is where inhibitions are. The deeper areas of the brain, really way in your brain, are sort of, we call them the reward centers. And I refer to them as the sex, drugs, rock and roll, and mood centers. And there's this constant competition here between this. Well, we were just chatting right before the webinar started about lunch, and you may have had a small dessert that you had with lunch, and you say to yourself, gosh, I would love a little bit more of that dessert. This comes on, your reward center says, I want more dessert, more food. The inhibition center turns on and says, no, you can't have any more. You're going to have to be on the elliptical all afternoon if you have any more. So there's this balance between that. And we know ADHD affects this, and the inhibitions aren't as good with ADHD. And we know from Scott and others' work that your reward center says, I like. Most of the treatments we have are aimed at that. So we either try to improve this or we try to reduce that. And that's a lot of our treatment works, both for addiction and those people who have ADHD and addiction. What I want to do now is ask the question, does treatment of ADHD in childhood impact later substance use? That is, giving kids stimulant medicines for ADHD, does that heighten the risk because you're giving them controlled substance? No. In fact, it reduces the risk. And one thing I want you to go home is treating ADHD across the lifespan, especially when you start the treatment early, helps reduce the risk for substance use. So here you can see the different studies, the countries, the sample size. Look at this, almost 3 million people with ADHD. That's huge. And then the different ages that they were followed through. And I want to point out, almost all the arrows are down. This one's equivocal, but it's a smaller study. This is the big one in the United States, 3 million. And if you look during the times people are treated versus they're not treated, significant reductions in the risk for substance use if you're treated versus not being treated. They also showed groups with ADHD who were treated versus groups who were never treated, improvements in rates of substance use in those people who weren't treated. So it is pretty much now fact that treatment of ADHD across the lifespan reduces the risk for substance use disorders. And then how early do you start that treatment? Well, this is data that Sean McCabe and us from the University of Michigan looked at. And that looks at ADHD and marijuana use. You know, I heard the poll question about marijuana, and it's a really poignant question. What is the marijuana effect? We know that if you start stimulants early, before the age of 9, and you treat chronically, that means over time, they look close. They're indistinguishable from the population. It's the groups where you start the stimulants later. Ergo, when do you start treatment of ADHD? We think before the age of 9, when you're like, well, do I need to start it now? There's probably differences. And by the way, this isn't the first study to show that. This has been replicated. So this is an important finding in terms of protection against substance use, and we think for other functional outcomes that I can answer questions but won't have time to go through. This is a big question that comes up all the time. I know this is complicated. If you treat people early with ADHD medications, does that increase the risk for cocaine, or methamphetamine, because they're stimulants? This is a complicated way of showing you the data that it absolutely does not. This is people who are starting their stimulants really early. This is the population controls. There's no difference. In fact, starting stimulants does better than using non-stimulants. The rest of these are just different times and how long you've been treated. But the bottom line is early onset treatment of ADHD doesn't increase the risk for cocaine and methamphetamine use over the general population. So that isn't true. We do worry about it, let's say with opiates. If you give people opioids and you look later, they're at higher risk, but not for stimulants for ADHD. So put that to sleep, not an issue. Again, going back to that poll question about marijuana, there is a lot of talk about marijuana and ADHD. It's the most common drug that's misused, the second most common comorbidity that you see. So in other words, if you start with cannabis users, marijuana smokers, and you ask, what's the most common disorder they have? It's conduct. But right below conduct disorder is ADHD, and that's been replicated too. So you see a lot of ADHD with marijuana use and vice versa. Now, we know it's associated with neuropsychological impairment. Some of it's the acute effect. So, if you smoke marijuana, there is an acute neuropsychological effect, certainly through the first hour and a half to 2. And what's interesting is the recovery from that may take up to 8 hours. So actually, if you smoke a joint or do a vape, you probably should wait 8 hours before you drive. The big question is there appears to be with early onset marijuana use, early onset in 16-year-olds, 15-year-olds, 14-year-olds, persistent executive dysfunction. That is time management, hierarchical thinking, those types of things don't get, you see about 30% of kids who never had an executive function problem develop one if they've been smoking marijuana during their teenage years. So it may set you up for permanent sort of brain functional problems if kids are smoking marijuana too early. There's also no evidence of more self-medication. So if you look at ADHDers and you say, do they preferentially self-medicate with marijuana compared to those who don't have ADHD who use marijuana? The answer is no. There's actually no difference there. Well, I don't know about you, but if you treat individuals or if you've been around people who smoke with ADHD, they'll say, oh, it treats my ADHD. And in fact, it's largely case reports about that. And they did a study, and here it's listed here. This is Cooper's study that was published a few years ago. They used something called an oral mucosal spray of equal amount of THC, tetrahydrocannabinoid, it's delta 9, and CBD, which is cannabidiol, the active constituents of what you would get with marijuana. Their primary outcome, the thing they said that was the most important, there was no cognitive or activity improvement. They did not show, they missed their there was no major difference there. On their secondary outcomes, other things they were looking at, theoretically, you really can't comment much about that, but I think it was important because it was a small sample. They wanted to see either there was no change or there were some trends to improvement in some symptoms of inattention. So maybe trends toward improvement, but then all of the other issues that are associated. So the only real trial is that. Now, there have been questions about dose and other things. Certainly it needs to be replicated, probably in a larger sample. But the initial it's not, at least the effect is not like a robust effect. So what do you do with individuals with that? So we reviewed the literature and looked at all the different studies. And one thing we found that was interesting is that consistently structured therapies seem to be effective in treating adolescents and young adults with ADHD and substance use. In particular, things such as cognitive behavioral therapy and specific types of CBT that are adapted for substance use that you may initiate it with, and then sequence cognitive structured therapies for ADHD. And you go back and forth between focus on substance use, focus on ADHD, helping people understand, identify how they're feeling, come up with coping strategies to deal with cravings, urges, keeping themselves out of high-risk situations, managing ADHD-related issues that may interfere with substance use and its treatment. So that seems to be very important. And there has been one study that does seem to support that, but more is necessary to really get a good sense. What about medications? First of all, we do treat people with current active substance use and certainly people who have had past history. So I'm going to diffuse that right away. I think if you never think about using treatment for ADHD in these individuals, it's a problem because you're discriminating against people and because we think that there's improvements that I'll show in outcomes. So let's talk about what studies have been done. This is largely adults who have ADHD, in this case, cocaine addiction, all of them against a backdrop of receiving methadone maintenance for opioid use disorder. So all of them have opioid use disorders that are treated with methadone. They also have cocaine, which is unfortunately common for people who are being treated for opioid. They start getting involved in cocaine and ADHD. And this is asking the question, does higher dose mixed amphetamine salts XR, the branded name is Adderall XR, does that improve outcome for ADHD and does it improve outcome for substance use? Let's focus on this first. This is the percent of people who respond to placebo, 60 and 80 milligrams of mixed amphetamine salts XR, which is also called Adderall XR. And you can see that these are significantly better than placebo. So it does help ADHD response, and that response is 60 to 80%, which is what you get in an adult ADHD trial if you treat them with that same medicine. Well, what about substance use? So here, higher scores are worse, lower scores are better. This is placebo. 80-ish% had cocaine use positive urine in the preceding week. This is with 60 and this is with 80. So you have like a dose-dependent reduction. So here you have reductions in substance use, and here you have increases in improvements or percent responders of ADHD. So it improves ADHD, it treats it. But look at the doses. 60 and 80 are what we call robust doses. This is a study of atomoxetine, which is also branded as Strattera. And what this shows is if you give this atomoxetine to everybody and you look at heavy drinking episodes, this is what happens if they don't get atomoxetine, and this is what happens if they get atomoxetine, and that's a significantly reduced amount. Did it work on the ADHD? It did work on the ADHD. It had a very good effect on ADHD. And it reduced heavy drinking episodes. Did it keep people from drinking? No. Everybody was drinking, but in some ways you expect that because it takes a while for Strattera to work, to get to the right dose, etc. So again, another evidence that this is another treatment that you can use for people who have substance use disorders and have ADHD. And why do we care about treatment, especially in populations with substance use? Again, do we treat through active substance use? Yeah, you can. In fact, there's data that we just published this, and this looks at individuals who are in treatment for a substance use. All of them have ADHD. This is a fraction of people who stay in treatment. So let me tell you something very straightforward about treatment of addictions. If you stay in treatment, you're much more likely to get better. If you drop out of treatment, you're much more likely to have a relapse and use again. So you want this. You want everybody to stay in treatment. This is what happens if you treat ADHD, and this is what happens if you don't treat ADHD. Huge difference between the untreated ADHD and the ADHD. The other thing we noticed is that most of that occurs in the first 90 days of treatment. So it's really important early on to say, you have ADHD, let's try treatment for you to see what we would do. And what are some of our strategies? So you need to think about treating ADHD in the face of SUD. So if somebody has substance use, treat ADHD. If you have ADHD and substance, you've been following to develop it, what do? Well, if they have misuse or less severe substance use, keep treating the ADHD. So if you've got a patient of yours that's still smoking, or you're somebody who's still smoking a little here and there, there's no reason not to continue treatment because it continues to treat your ADHD and maybe protecting a little bit from your substance use getting worse. On the other hand, if you have more severe substance use, you're drinking multiple drinks every day, you're smoking every day before school smoking, there's dysfunction because of it, you're going to have to address the substance use disorder. You got to do something with that. If you're unable to address it, or if the person continues to use substance use, then what we recommend is get them involved in a very structured therapy, cognitive behavioral therapy, that focuses on addiction and then ADHD. Use non-stimulant medications. Those are important because they can help you in terms of treating the ADHD without concerns of misuse. And I'm going to talk about stimulant misuse at the end of this presentation, so we'll get to that. But they're also helpful non-stimulants because they can help co-occurring problems. So we frequently use, for example, atomoxetine, which is the branded name is Strattera, and other ones like bupropion, branded name Wellbutrin, for people who may have anxiety or mood, because it helps not only the ADHD, but the other disorder also. If you're going to use stimulants, you're thinking about using either the extended release stimulants or the prodrug stimulants. Prodrugs are there's two newer stimulants that are prodrugs. That is that they're not active until they get cleaved in the system. One's called serdexmethylphenidate, dexmethylphenidate, and the other one is lisdexamphetamine. Both of them, one from amphetamine and one in methylphenidate. But at the very least, use extended release. Why? Because I'll show you the immediate release are misused. And this is a big issue. And more there's abuse deterrent stimulants. And that is the extended release ones that I spoke about, the prodrugs. And there's other ones that are still in development. So I'm going to end this whole set of presentations talking about what do we know about stimulant misuse? or referred to as the non-medical use of stimulants. Well, this is when it's happening. Look at this, 18 to 25. That's when you're getting most of it. And if you ask, where does it take place? At universities, in the trades, in the military. It's at universities. It's in college. This is really this group in college. That's where it's occurring. We know that there have been a number of studies, and most of these are survey studies in college students. And in general, of the college students, up to 20% have used stimulants non-medically. And that means either you were prescribed and you were jacking the dose or using them at night to party and other things, or you got it from somebody else. You don't have a diagnosis and you're using it for things like studying and stuff like that. Now, if there are providers on, I want you to know that the most of them get them from friends. The majority don't scam local doctors. And if you ask them, why are you misusing this? They're like, they're not dangerous. It's okay to misuse. They also don't know the ethical creeds and other things that are a problem. We did an NIH-funded study, and we looked at the reasons for misusing stimulants. And notice this, the vast majority use them to concentrate or focus better. Sounds like a lot of ADHD to me. In fact, they have higher rates of ADHD. They also use them to stay awake, which is the side effect, to get more energy. And then you have some that just use them to have a good time with my friends. And we did a study, 15 years ago now, that showed that 1 in 5 individuals are misusing their stimulants to get high. So we got to watch that. And again, most of that is with the immediate release. It's hard to do that with the extended release. You know, I made a comment, sounds like ADHD to me, and this is the difference. These are people who misuse stimulants. This is people who don't misuse stimulants, and it's about twice the rate of ADHD in that population. So ADHD does run with that. The other thing, and I'm not going to go into that, is you see a lot more misuse. I mean, you see a lot more other neuropsychological problems, like we talked about earlier. Time management, organization, things like that are also more problematic. Remember I made the comment, we want to stay away from immediate release when we're working with high-risk groups. You know, high school students are in boarding schools, college students. Immediate release stimulants are misused by college students. And you just see it here. This is mixed amphetamine salts, IR, that's Adderall. And then some don't even know what they're taking, and then short-acting Ritalin, methylphenidate class agents. This is one of my favorite studies. It's it's over 15, 16 years old, but it's really cool. It shows the difference between giving an extended release stimulant and a short-acting. It goes into I'm just going to say the punchlines. It goes into the brain differently. This is the immediate release. More of it, see that number is higher, so it goes like that. And it climbs steeper and higher, and that steep and higher gives you high. Here, if you look at how high you get or like the drug, this is the blue. Look at that. This is immediate release methylphenidate, Ritalin, and this is extended release methylphenidate, Concerta. The same dose, just given differently. And look at binding in the brain predicts what happens. So because of this likability, how much you like it, we recommend these for people who may misuse stimulants because there's not a lot of likability of the extended release. The other issue we're concerned about with stimulant use is that there's misuse of largely short-acting by snorting it. 40% snort their medication who misuse it. And I talked to one of my nephews who claims, I didn't do it, but I asked him about it, and he was, in a fraternity, and he said, oh, yeah, they do it because they want the effect right away. They don't want to wait the half hour to 45 minutes. And if you snort something, you inhale it, it does happen much quicker. Here's another thing. We're talking about prescription stimulant misuse. This is hot off the press. This is, again, the group that we work with, Sean McCabe and the rest from the University of Michigan and Texas. And what this shows is this looks at cocaine and methamphetamine use. I'm just going to highlight. This is the rates in the general population. This is the rate if you treat ADHD and you're following them through the ages of 19 to 24, and you have no misuse of the stimulant prescription, so it's no different. So again, showing you that taking medicines for ADHD and doing it appropriately doesn't increase cocaine, doesn't increase methamphetamine. So what are these two? This is misuse, prescription misuse. If you're misusing your prescription of ADHD medicines, look at the high risk of cocaine use. Almost 15% develop cocaine use and 8 or so percent methamphetamine use. And this is a group that don't have ADHD that are just misusing prescription stimulants. And you can see high rates of cocaine and methamphetamine. So these two groups here, the red and the green, the Christmas groups, are the ones that were misusing stimulant prescriptions. So it's not trivial when people misuse stimulant prescriptions. And where do they get them from? And so this is another study that we were involved in. There's a group of us that work together. It's a great group, lots of fun. But one of the things that they show is that where they're getting the stimulants from are what's called reservoir medication supplies, which is excess numbers of pills caps. This was more of an issue previously when you would have to send kids to school, college usually, with their medicine, and they couldn't get refills. So they would take 360 tablets. Well, the problem is when you have 360, you lose track of how much do you really need, and somebody wants them, so you give them some, and then somebody else wants to buy them from you, and you have so many, it's like, what's the difference? So what we call it is right-sizing the amount that you're giving people. And since you can send prescription stimulants across state lines, and many pharmacies will honor the prescription, I always tell the practitioners who are writing for stimulants, right-size the prescription. If they need 30 for a month, give them 30. If they need 60, give them 60. Don't give them 90. Don't give them 120. Give them the correct supply, because people are a lot less likely to divert, give to other people, or sell to other people if they have a limited supply of what they had. So what are some things that parents, practitioners can do? First of all, understand about prescription drug misuse and substance use. So just know about it, talk about it. Learn and communicate the medical, psychological, addictive, legal issues. So some of the legal issues, is let's say somebody's getting amphetamine and they get 20 milligrams and they get 30 or 60 of those. If they're selling them to somebody else and they get caught, that's a felony offense because of the milligrams that they're selling. So they may be giving away 6 tablets, but if these were 30 milligram tablets, that can put them into a felony arrest category because of the milligrams that they were saying. There's also ethical creeds by most institutions that you are not allowed to do that. And if you do, you can be expelled, academic dishonesty or other ethical charges. The other thing is consider non-stimulants and extended release or prodrug stimulants. I was talking about this before. These are the 2 prodrugs. The the Liz-Dex gets sliced. Let me go back. The lysine gets sliced and you get dexamphetamine, and the serine gets sliced and you get dexmethylphenidate. That's what happens. And these are good extended release stimulants that have good efficacy and appear to have lower abuse liability. Don't overprescribe, and don't keep controlled substances in medicine cabinets. That's where people misuse them. And don't advertise to people that you're taking stimulants. So in summary, since ADHD is a risk factor for cigarette smoking and substance use, teenagers and young adults with ADHD need to be followed for all of that. By the way, do we do urine and oral fluid tests? No. We ask about substance use. And there's automated ways to do that, or you just ask how much you're using, etc. You do best if you give them a paper, pencil, or an iPad to fill out. ADHD should be considered in adolescents and adults who have cigarette smoking or substance use. Treating ADHD helps protect against the onset of cigarette smoking, substance use, and criminality that may be linked to that. There are strategies for managing substance use disorders in ADHD. Go ahead and treat. And since stimulants can be misused, consider mitigation strategies. Extended release versus immediate release. Talk about it and keep an eye on what you're doing. And with that, I am going to end my presentation and hand this back over to Carol.
Okay, well, thank you for such an informative discussion. We really appreciate that. Before we start the Q&A, I'd like to thank Inflow once more for sponsoring this webinar. I'd also like to share the final results from today's 2 poll questions. Here's what you said. In your personal and or professional experience, has marijuana use among patients with ADHD increased in recent years? 78% say yes, and 22% say no. Probably not a big surprise there. And have you or someone you know been denied your ADHD medication because of substance abuse concerns? 39% say yes, 61% say no. Which is a good segue into the questions, because we got a lot of questions and comments from people who say their clinicians or long-term residential rehab programs refuse to provide stimulants for their ADHD because of their substance abuse history. So I had a few questions around this. One is, how do we get prescribers to understand stimulants are needed for proper treatment? And I have a question from an addiction counselor who says, I'm working with patients who have opioid use disorders. They're now on methadone. Many of these patients have untreated ADHD. Would you as a clinician consider prescribing stimulant medication for people with this addiction?
So these are great questions. And first, I got to start with the poll question about marijuana use with now that it's legal. One of my fellows actually did a survey, a meta-analysis survey study looking at all of the literature about states that have both medically and recreationally legal marijuana. And in fact, found increases in the amount of marijuana use if you look independently at survey studies of the kids that were done. So in fact, I would agree with the majority that yes, there is an increase in marijuana use with legalization. So to your questions, first of all, how do you change the perceptions around this? I would, use the webinar slides and say, look, this is what people in the field who work and have thought a lot about this are doing now. I think, first of all, helping people understand that there's ADHD, that there's impairment, and that by addressing the ADHD, you're going to keep people in treatment. That study that we published in the Journal of Clinical Psychiatry is really important for that. You enhance people's ability to stay in treatment. That's really critical for substance use. Number two, if you look at the treatment algorithm, it isn't start with high potency, short acting stimulant that can be misused. In fact, it starts with, let's start with good diagnostics, but cognitive behavioral therapy, use structured therapies, and then try non-stimulants. And we have atomoxetine, we have viloxazine XR, we have alpha agonists, guanfacine extended release, we have off-label bupropion, tricyclic antidepressants. And I do that. And then if that doesn't work, then I move to stimulants. Unless the people have been tried on those previously with ADHD and they didn't work. And most of the people I treat, they're willing to try it, and some get better. They like it because this drug works better for their ADD and their anxiety or whatever. So that's how it is. You don't necessarily have to start right with the stimulant. To the question about opioid use disorder, again, I want to remind you that study from Dr. Levin that I presented using high doses of mixed amphetamine salts XR, again, the brand name is Adderall XR, was in people who have opioid use disorder with methadone who also had cocaine and ADHD. So there's an extra level there. And would we treat them? Absolutely, we would treat them. Again, you would start typically with a non-stimulant medication and then move to a stimulant medication. Another frequent question I get is, if you have somebody come in who is an adult with ADHD and they've had a past history of substance use, what do you consider a, quote, safe past history where you might just start with stimulants? And, that varies. Most medicine studies that were done would say anywhere between 6 months to 1 year, you're okay. And in those studies, there was no evidence of misuse or diversion of the stimulants. And the people with past histories of substance responded equally well to the stimulants. So you certainly, from sort of historic 6 months out, people who work with substance use would say that may be a little bit too conservative. Maybe 3 months not using substances, being in remission would be fine. And again, there are a lot of people now who are saying, if you have current active substance use, start with non-stimulants, start treating them, start working on them right out of the gates. And don't discriminate against people because they have a substance use history. And I treat some people who have had histories from 10 years ago. And all I do is I say, if anything I'm giving you is making you more likely to use, let me know, and we'll talk about it.
We've had quite a few questions around this, does using stimulants for ADHD over a period of years cause addiction to stimulants?
Yeah, and the answer to that is unequivocally no. Now, can I say that there's never a case of that? No. But if you look at the world literature, and I was showing you really the big literature in all of the big registry studies, we're not showing significant worsening of addiction over time. And what we find is more of a protective effect. And we published a paper just a few months ago that looked at the literature on does pharmacotherapy of juvenile ADHD, mood, anxiety, et cetera, does that increase, decrease, or have no effect on ultimate substance use rates? And the preponderance of studies showed improved substance use rates. And most of those studies were with ADHD. So no, the giving controlled substances doesn't increase the risk. We know that. And we think that it actually, based on the world's literature and the studies I showed, reduces the likelihood to smoke cigarettes or to have a substance use disorder later in your life.
Does cannabis affect medication for ADHD, anxiety, and depression? A few people have asked.
Yeah, there was a study that was presented, but I could never find the actual study, where they actually show that smoking cannabis sort of negates the effect of, in this case, methylphenidate or Ritalin, that it actually diminished the impact. And my sense is that that's what I see clinically, that if people are responding well and they smoke too much, you see worsening of the ADHD response with the medication. Now, in terms of drug interactions, cannabidiol, CBD, so people use cannabidiol all the time, or if they're smoking, they have some cannabidiol. You would be a little bit concerned about atomoxetine or Strattera because they both are metabolized by liver enzymes, and they both inhibit the liver enzymes to some degree. But in fact, if clinically meaningful, has there ever been a bad outcome because of that? No. But cannabidiol actually has more than others.
Someone writes that he uses marijuana to slow down his thinking and as a sleep aid, and wondered if there were risks to this, though he didn't talk about whether he used ADHD meds or not. But he says, if there are risks, what are they? And do you recommend an alternative?
Yeah. So it really is an age dependent issue. If you're, 16, 17, 18, yeah, I think there are risks. The United States is spending over $300 million in a big project called ABCD, where they're studying the outcomes of individuals' brains over time. And one of the questions I have is, does exposure to early cannabis change brain structure and function? Currently, the data would suggest yes. And they're trying to figure out if that's there. To your question, if you're a 40-year-old or 50-year-old and you're having one or two puffs of marijuana, which is more medicinal, and you're not drinking, you're using that instead of drinking, I would maybe make the argument that that's safer than drinking. You're not going to have you're not going to have liver problems or anything like that associated with it. So yeah, if you're medicinally smoking marijuana, again, notice that one or two puffs. Medicinal marijuana is not 6 joints or vapes, multiple vapes a day. It's one or two puffs. And yes, and people also will say that for pain control. Do I think it's a problem? No. If it's age, you're not driving, and if you're doing that instead, and that's helping you sleep and stuff, yeah, I think that's reasonable. And if you're using it for its anxiety properties and stuff, get a higher CBD grade. Higher the CBD, probably the more medicinal and the less addiction component you have to worry about with it.
Psychedelics are being researched for treatment of certain medical disorders, I think particularly PTSD. Can you tell us if there are psychedelics being researched for the treatment of ADHD?
I am unaware of psychedelics for ADHD. I do not know of that, and I don't know of people who are doing that work. I do know that there are other things being researched, like neurotherapeutics, direct cranial stimulation, both for ADHD and for executive dysfunction that's associated with ADHD or other psychiatric disorders. But in terms of psychedelics, I'm unaware of any research in that area.
What types of non-stimulant medications are available to quell addiction behaviors? I believe the event of dopamine deficiency is involved besides just needing to increase electrical activity in the prefrontal context region.
Yeah. So the medicines that we've used, so I showed you data with atomoxetine, which is Strattera, and that helped reduce episodes of heavy drinking, and it treated ADHD. So Strattera is one that's been examined. We also published papers showing it really doesn't have a lot of drug interactions, drowsiness being the most common with substances of misuse, including alcohol and other drugs. Other things to think about would be bupropion, Wellbutrin. That's been used for ADHD. It's not on label, but we've used it. Pretty much every study shows it's positive. It's been used for cigarette smoking. We've used it in kids who also have mood, ADHD, and substance use. And in open studies, it was effective. There's interest with tricyclic antidepressants, tricyclics like desipramine and imipramine. They help ADHD. They've been tested with substance use and with substance use, but great for ADHD. Guanfacine extended release has been studied in adolescents and young adults. It works for ADHD. It's not been tested with substance use, but it shouldn't cause issues with substance use. And finally, another medicine that we just don't know in context of substance use is the new one called Viloxazine XR, which is Qelbree. And there we would expect it to have an effect, probably for ADHD, maybe for mood also, and maybe for executive function as part of it. The data seem to show that you improve ADHD, and if you can improve ADHD, then you can improve substance use. So that seems to be the way it works, that it improves the ADHD and it improves substance use.
Someone writes, I found that coming down from my Adderall used to make me crave alcohol, and I was constantly binge drinking. Have you heard of this from others? And yeah,
I absolutely have. And I thank you for, highlighting that. It is what I was saying, that anytime you use stimulants in somebody who has substance histories, I always ask people, is it creating cravings? And then if it is, where is it? I don't want to scare them away because I don't want people to say yes and then I pull it, because I try to work with them. In this case, I've certainly heard that during crashes, and crashes are really are like airplanes coming out of the sky. If you notice how an airplane comes out of the sky, they come out of the sky pretty steep until they get close to the runway, and then they flare. And for drugs, for medicines, they just sort of come down like that. That last part of what we call the descending curve as the drug leaves the body, some people can really experience a crash. And what you can do is give them very small dose of the same medicine, very low dose of Adderall, just a sprinkle of it about a half hour before that. And it creates a flare like an airplane does right when they land. And that can get rid of the crash. That's what I use in practice all the time, to get rid of the crash, because that can be problematic. And last thing we want people to do is to get cravings, urges, use because of the medicine.
An ADHD coach says she feels it's very hard to convince kids to take extended release ADHD meds because they don't like the way it makes them feel. They want it in their body for the least amount of time possible. What do you think?
Yeah, there are a certain number of kids like that. And, a lot of what I do when I'm treating people with ADHD is not just getting the symptoms down, but then trying to pick a medicine that sort of lines up with wellness. So I will move the different type of medicine. I will shift it from this type of methylphenidate to maybe a dextromethylphenidate. There's so many various preparations available. I have to carry this. I mean, this just shows you a guy named Dr. Addisman from New York put together all the different stimulant types and everything, because there's so many of them now. And because of that, we have options for people so that they shouldn't feel that. If they feel zombie, I do this. If they feel that they don't like the effect too late or sleep, I do that. Can you shift them to immediate release? You can. We try to not start with immediate release, but there's a lot of people on immediate release and they can do really well with them. Do I monitor them a little bit closer? I do. And I keep reminding them that not to give it away, not to sell it, not to misuse their own stimulants. But yeah, it's not like I want everybody to be afraid of immediate release. But in general, as a public policy, start with extended release in higher risk groups.
When treating ADHD in people with concurrent cocaine use disorder, is there any cardiac monitoring or worries about a cardiac event?
Great point. And in fact, there's a guy named John Grabowski and a guy named James Negro who had done a lot of work in that specific area. And they had to do that work with the National Center on Drug Abuse. So this was published 20 plus years ago. And they did not show significant cardiovascular effects. And in Dr. Levin's study, she did not show cardiovascular effects. So in fact, whereas you certainly think there's what we call plausibility, it's something you would worry about, it does not seem to be a big issue. And anything you can do to cut back cocaine use, which does have cardiotoxicity, would be great.
A coach asks, how do I respond to parents who refuse prescription stimulant medication to treat their child's ADHD because they're worried about addiction or misuse?
Yeah, so I would say to them, that is a solvable problem. If you're administering it to your kids, the likelihood of misuse goes to almost zero. So if you're monitoring and supervising the administration, it's going to be fine. Number two, long-term, the data show that treatment of ADHD reduces risk for substance use. So not treating is going to cause the biggest issue. And honestly, stimulants are the most effective agents we have for ADHD. For this individual, I would say, hey, let's start with non-stimulants. You'll feel better. Your kid is. And by the way, for some of the non-stimulants, you're more likely to have a response if you start with a non-stimulant as opposed to a stimulant. And if they work, great. If they don't, then we can move to stimulants and we'll use extended release and you'll supervise and monitor them. The concern about, them misusing their own prescription, et cetera, is a real concern. I actually appreciate that. As I showed you, misusing your own prescription is either a marker, that means that it's telling you there's something going on, or it's causative. But if you look 5 years later, those are the people who are getting involved with substance use in general, excuse me, or having problems with other things, cigarette smoking, occupational problems, et cetera. So we don't want people misusing their prescription. And as long as they're at home, parents can monitor that.
This one parent writes she's having a hard time getting her 17-year-old son who uses cannabis to stop using it. He also takes stimulants. And she says she's really struggling to get him to stop. She's worried about the long-term effects and if you have suggestions for her.
Yeah, it's really hard. And I think that, working with somebody who can sit next to you, going to parent groups around this is important. We have an addiction recovery management service. We have an outpatient service, and probably half at least of our patients are exactly what you're describing. 16, 17, 18-year-olds with heavy cannabis use. They're convinced it's great. There's all these websites dedicated to show that. In fact, for that young a brain, it isn't okay. There's probably some neurotoxicity. We don't like it. It does affect cognition. There's neuropsychological complications, both short and long term. But working with somebody, they can help you because there are some contingency, management techniques you can use. You can't drive, you can't do this, you can't do that. I also say don't make it easy for your kids. You announce to them in the future, in 1 week or 2 weeks, I'm going to be going through the house. I'm going to throw out anything I see. In 1 week, I'm going to go through the house. And then you start going through the rooms, everything, and you get rid of stuff. Don't make it easy for kids to use. And by the way, if you're smoking, get rid of your own marijuana. Don't smoke and don't even smoke. And I love people who say, oh, my kid doesn't know I smoke. I always joke. They know you smoke. Of course they know you smoke. And not only that, they're probably smoking your marijuana. So be careful about that. I would keep it away from kids. Don't smoke around kids. And there's also data that its most vulnerable ages to smoke around kids is probably between 12 to 15, because that's when they start developing their early habits for substance use.
And we have a question. My kids say they like the energy that they get from stimulants. Is this okay? Does it prevent them they say coming off of it is a problem. They don't like the feeling when they come off of it.
So, you mean they like the energy? So there's coming off of it. Does that mean when they stop them, like on weekends and holidays, or every day during the wear off phase?
Well, the question doesn't specify.
So what I would say is, let me. I already address the wear-off phase, just give low doses or try a different preparation. But for people who they say it helps them with energy, arousal, and stuff, there are some people, Russ Barkley, who's a maven in this area, talks about sluggish cognitive tempo and things like that. And what certain think is that there's just some people with ADHD have low arousal. It's hard for them to get going, their cognition to get woken up, to initiate, and the medicines help. And then when you don't have the medicine, you don't have that, so you're sluggish. That doesn't make me nervous. I've treated a number of people. None of them have gone on to have an addiction because of that. But for people like that who say, but it's hard for me to come off the stimulant, what I say to them is take half doses or quarter doses on the days you're not using them. Just take a low dose, and that usually will help your arousal. And it won't really do a lot for your general cognition, but you don't really need them on that day. And if you're coming off and you're worried about that, just cut the dose back in half for a few days, take it away, and that probably will automatically reset your brain.
Well, unfortunately, we're out of time, so that has to be the last question. But we thank you so much for joining us today and for contributing your expertise to this ADHD community. Make sure you don't miss future Attitude webinars, articles, or research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 440 to access the slides, the webinar replay, there's a certificate of attendance option, and the webinar transcript. And if you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine. In the forthcoming spring issue, you'll learn about the latest studies on stimulant use and heart health. And here's a hint, it's good news. And you won't want to miss our cover story on how to fix relationship problems when ADHD is in the mix. Our expert therapists weighed in with the practical solutions they recommend to their clients. Subscribe to Attitude Magazine today for your family or to share with a teacher or a loved one who could benefit from greater ADHD understanding. Thank you all. Have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.